Hello, everyone. Good evening. Welcome to Cord Connects. My name is Moshe Weitzberg. I am a member of the Cord Board of Directors, and I would like to welcome you to tonight's edition of Cord Connects. Our session tonight is on the flipped classroom, and I would like to introduce our speaker for tonight, Dr. Robert Cooney. Dr. Cooney received his medical degree from Jefferson Medical College and completed residency training in emergency medicine at Allegheny General Hospital. He then went on to earn a master's in medical education from the Lake Erie College of Osteopathic Medicine, followed by completing the Alliance of Independent Academic Medical Centers Institute for Healthcare Improvement Quality Improvement Scholars Program. He is currently an attending in the Department of Emergency Medicine at Geisinger Medical Center and serves as the program director of the Emergency Medicine Residency Program. His interests focus on the intersection of education, quality, and technology. It is my pleasure to turn the floor over to Dr. Rob Cooney.
Thank you, Moshe, for the introduction, and welcome everybody. This evening we are going to delve into the history and the basics of getting started with flipping the classroom in emergency medicine. As we begin, I have no major financial disclosures to disclose to you. I will be discussing multiple different software platforms, and I do not receive money from any of those. That being said, I am a faculty member for the Chief Resident Incubator and the Faculty Incubator of Alium, and I do receive a stipend from them. And then I have recently started working with Emergency Medicine Foundations as well as a member of the asynchronous content team. So today what I would like to do is delve into the definitions of the flipped classroom, and there are many. Go through the history of the flipped classroom, which is actually somewhat fascinating. Then we're going to take a bit of a dive into the literature about the effectiveness of the flipped classroom, especially in medical education. And then we will finish the session by going through some pearls and pitfalls so that you are able to take the lessons home and then apply them yourself for the flipped classroom. When we think about how education works, a lot of people will think about the traditional classroom, the large lecture hall with the teacher down front, the sage on the stage, if you will, looking through their notes, putting materials into a PowerPoint or onto a blackboard and delivering that to an eager group of young students who are in the audience taking down notes these days by computer and not by hand. Unfortunately, that doesn't work really well when it comes to the outcomes that we want to see in our learners. And one of my favorite quotes about this comes from Eric Mazur. And he's absolutely correct that if we really want our learners to be able to demonstrate what they've learned, we can't have them sitting passively in the audience. They need to be active participants in their learning. And that brings us to the definitions of the flipped classroom. So the flipped classroom is a pedagogy that, for all intents and purposes, flips traditional lecture on its head. In the traditional classroom, you generally have a teacher or an expert who delivers content, usually via lecture, to the audience, and then afterwards, if this even happens, the audience will go home and they will spend time on their own going through problem sets or some type of homework. But we know in medical education that this often doesn't even happen. Usually the learners will show up in class and they'll sit passively in the audience watching the presenter, and then they will go back to the real world and they won't do much afterwards. The flipped classroom, on the other hand, tries to push the low-level knowledge out to the participants. It delivers it, and then they come to class prepared with some foundation knowledge, and they try to put that to use with the teacher guiding some type of exercise. And we'll get to the different options later in the presentation. But the key part is that it's instructor guided and quite active. And that brings us to the definition of the flipped classroom. So the flipped classroom is a pedagogical approach that moves the direct instruction from the group learning space where we're all together and puts it out to the individual so they can learn on their own time and at their own pace. And then the classroom or the group space now becomes a very dynamic and interactive environment. And then the other important part here is that there must be an educator to guide students as they take those concepts and apply them. They can use creativity and they really dig deep into the subject matter. So when you look at that definition, you kind of can almost predict the history of the flipped classroom. When you look at delivering content to learners and then making the classroom an active space, that sounds like a lot of different techniques that have been out there for millennia, case-based teaching methods and things like that, even problem-based learning within the medical education sphere. The problem is that you really need to have some type of instructor prompt or guidance in both the individual and the group learning space to truly fit into the flipped classroom pedagogy. We need to support the active learning, whether it's when the students are independent or whether it's when they're with us learning together. When you think about it through the lens of medical education, probably the first flipped classroom was actually William Osler's Journal Club. Necessity is always the mother of invention, and so in 1875, he proposed a journal club to his colleagues so that they could save money on the cost of the print journals. But he was actively involved in helping to select those different sources, and then when they got together, they would actively discuss the concepts that they were reading and how they applied to their clinical work. Fast forwarding, the earliest demonstrations that we really see of the flipped classroom as we interpret it through the modern lens is probably Eric Mazur of Harvard. He developed a system called peer instruction in the early 1990s. And this all started because he had read a paper that showed that physics students were doing really well at applying the mathematical concepts of physics, but when they actually had to answer pragmatic questions about how physics applied, that they were stuck in pre-Newtonian thinking. And so he thought, well, my students are probably better than this, gave the students the test, and these were students in his physics class who were destined for medical school, so our students. And lo and behold, his students did exactly as predicted by the other instructors, and they did really well on the concepts, but really did not understand the pragmatic applications. And so being a good teacher, he decided to go back to the drawing board and develop his system for peer instruction. It started with a mini lecture or a demonstration in front of the class, and then they administered a concept test to the students. They used clickers for the students to vote on the answer, and if there was a consensus on the answer, i.e. the students got it right, the class would move on because in his mind, they got it. However, if there wasn't a consensus and he set the bar at 75%, he had the students pair off, and then they would take turns arguing in favor of their position, whether it was wrong or right. And then about 2 to 5 minutes later, he would re-poll the audience. And what he found is that when students were teaching each other and arguing their points, that they actually co-created the correct answer more often than not. And at the end of the class, he saw a 2 to 3 standard deviation improvement in the physics knowledge test score that he had administered to the learners. Meanwhile, in Ohio, J. Wesley Baker was starting to introduce this through computers as what he called the classroom flip. And he was a design instructor. He had one computer in 1995 for the entire class. And so initially he was showing up, presenting the information to them, but they had an early intranet. And so he was able to actually deliver the slides to the students. And once he started doing that, the students, readily took to it, but he kind of smacked himself in the forehead on his way back to his office the one day as he thought, oh no, I just gave away the entire core content to the learners. What am I going to do now? And so he sent out a famous memo to his learners that you can actually find online. And he wanted his students to do 4 things while they were together in class. First was to clarify the concepts that they were learning through the PowerPoint system on the web. Then they were to expand on the concepts using their knowledge gleaned from other classes. Then they were to apply the concepts to a project they were working on, and then finally practice with some of the other students on the application phase as well, so that it could feed back to their end of semester project. And it worked really, really well for his inaugural classes. And he was describing it to one of his colleagues who said, so basically what you did is you flipped the lecture and the homework around. And that was probably the first instance that we've seen the word flip used in the educational realm. In the early 2000s, we have Bergman and Sams, who are mainly attributed with coining the term the flipped classroom. They are two chemistry teachers from Colorado, and they did this out of necessity as well. Their students were traveling a lot for sports and other activities, or they may missed some classes, and they found that they were spending a lot of time teaching makeup content to the learners who had missed the classes. And so one of them had actually seen an advertisement in one of the teaching magazines for screencasting software, talked to his partner, and they decided to try screencasting their lectures. And it was right about the time that YouTube was going live as well. So they screencasted their lectures, put them up on YouTube, and then sent them out to all of their students. And they found that the students really loved the stuff. They were able to pause and rewind, and they found that the students actually were preferring the recorded lectures to their actual classroom lectures. And this also caught on with some of the local districts, and they were invited to do educational development sessions for some of the other teachers in Colorado. And it was picked up by another gentleman who is a math teacher in Colorado by the name of Carl Frisch, who turned out to then be interviewed by Dan Pink, the famous author, who wrote an article about it and was the first person to refer to this type of learning as the flipped learning. Originally, Bergman and Sams wanted to call it inverted instruction, but flipped classroom stuck, and 2 years later they wrote a book about it, and the rest is history. They are largely credited with the wide dissemination of the flipped classroom. So the ultimate question for us as educators is, does it work? And as the picture kind of shows, it's kind of yes, no, maybe. I think to truly evaluate it, we do need to take a step back and look at Kirkpatrick's hierarchy with reactions. So did the learners like it? And then learning, and then behavior. Did they actually change something in the way they work? All the way up to the results, which in medical education is, do the patients benefit from teaching in this way? We now have several systematic reviews on the effectiveness of the flipped classroom. The scoping review was completed in 2014. The systematic review was completed in August of 2017. What they found is that learners, by and large, do prefer this method of learning. The low-level Kirkpatrick seems to be very positive with the learners. Unfortunately, the learning is kind of, plus minus. What we can say is it's not inferior to traditional lectures, but we can't really say that it's superior at all. And as of right now, there really is not a demonstrated change in the behavior in the clinical realm. So if you're listening to this and you're a educational researcher, this is ripe for some study. That being said, those studies are already dated, and we do have some other studies that have been published since. My friend Jeff Riddell performed this study looking at the flipped classroom in medical education. And what they did was they took a nationally recognized speaker, had that speaker deliver a lecture at 3 different sites, and then also record screencasts, which were only 20 minutes in length, and the learners participated in a crossover design. Now, this was really 2 sessions, and what they found is there really was no difference in the knowledge uptake. Their multiple choice exam scores were the same, whether they were in lecture or whether they were in the flipped classroom session. But the thing that they don't talk about really in their discussion is time. And here's their study design. So the participants went into a 50-minute lecture on topic 1 and then a flipped classroom on topic 2 and vice versa. And what you can see is that they only spent 60 minutes in the classroom, when they were in the flipped classroom part. And the other 40 minutes of time was actually pushed out to their daily life. So again, they could listen in, pause, rewind, revisit, listen twice, whatever they wanted to do. And so I think what this really shows is that if it's equally effective, then we can really save some time as educators by moving towards this model and allowing the learners to consume the passive content or the low-level content on their own time. Also published later that year is this trial from the pharmacy literature. And they did show some pretty interesting results. And if you download their article, they have this wonderful infographic in it that demonstrates how they took the entire curriculum for the pain management module and flipped it around. So in the traditional side there, it was mainly lecture-based with a little bit of problem learning and some slides down at the bottom. And you can see they went from 600 to 259 PowerPoint slides delivered to their learners, with a significant increase in the amount of the flipped classroom activity. And what they did is they then put their students through either an OSCE, they put their students through an OSCE and a multiple choice exam. And the results were pretty impressive. So the traditional OSCE is on the left, the flipped OSCE is on the right, and you can see how they really move the tails of their distribution into the positive for those students who participated in the flipped OSCE. And so this kind of begs the question, does it work? And I think the answer really is yes, but. The signal in the literature, although we can't really say for sure, seems to be that the longer the students engage with the flipped classroom environment, the better they will perform over the long run. And I think that makes sense when you think about it, that the learners are used to learning in the traditional setting, and they almost have to learn how to learn again. And so the more time that they spend interacting and figuring out how to learn in that environment, it actually really does result in better learning outcomes over the long haul. It remains to be seen whether we can prove it, and I hope that we see some literature coming out in the next 2 or 3 years that shows that. So how do we do this? Most people are familiar with lectures. Lectures are comfortable and they're really easy and they do work. And right now we can say that flipped classroom isn't that much better than lecture. But if you wanted to do this, you have to kind of cross a couple of hurdles. Again, we're splitting up the work into 2 instead of 1. And so we need to figure out before class, how do I deliver the effective content to the learners? How do I make sure that they're actually doing the work? And what if I can't find good content out there? Then how do I make my own? And then when you're in class, what do I actually do with my class time? Because now it's a bit uncomfortable. I'm no longer standing behind a podium with a clicker in my hand, but have to guide students through learning activities. And how do I make sure that my learners are on the same page, especially as residency educators, where we're teaching residents of different levels and oftentimes medical students as well? That question becomes really important. So step 1, creating content. My advice here is don't reinvent the wheel. There is so much good content already out there from expert speakers that all you have to do is spend a little bit of time looking, and it's very likely that you will find material that is really already pre-made for you. That being said, don't be afraid to give your students some reading. It's a highly underrated form of content delivery and readily available to all of us. Now, the students prefer podcasts from what we can tell when we've looked at some of the surveys. So, if you have that over reading, it may be more preferable, but may not be educationally better. And then anymore, we really also have to consider how video may play a role. And we know from multimedia learning theory that when you can combine proper images plus the text, that the students should learn better than just having a podcast by itself or reading words by themselves. Now, with reading, a word of caution. Students need time, and we need to respect their time when it comes to reading. A Word document has about 550 words per page, compared to 1,050 for a textbook like Rosen's, or 870 for a journal article. And you can see scrolling across how long it's going to take the learners to actually engage in those content choices. The shorter, the more likely it is that they are going to engage and complete the work. It's not saying that typing up Word documents or sending them to blog posts is better than the textbook, but if we really want them to complete the work, we really have to respect them and their time. In video lecture, far fewer words, but with multimedia learning theory may be actually superior and is readily adopted by your learners. So where do we find the content? Well, in emergency medicine, we are blessed by the advent of free open access medical education. Emergency physicians were some of the earliest authors and recorders of this type of content. And since it's been out there for over 6 or 7 years now, there's a plethora of choices that you can draw upon. Life in the Fast Lane has a wonderful library of all of the different blogs and podcasts that are out there relevant to emergency medicine. But you could also just go to iTunes or whatever podcast aggregator you like, type in emergency medicine, and see what sources pop up. As you can see here, there's a lot of different choices when I just choose medicine in general. There's also Foam Search. It's googlefoam.com, and this is a database that uses Google's proprietary search engine to only search directed sites that was created by an emergency physician in Canada. So he filters through all of the irrelevant content, and actually this search engine will include major medical journals as much as possible in the results that it pops up. So a really good resource to use as an educator when trying to find the content. Now, once you've found the content, I highly encourage you to check out the quality checklist for blogs and for podcasts. As an educator, you're going to be in the editor or curated column in the middle. And so you can run through the checklist and make sure that the content that you are planning to use for your class actually meets the quality criteria that we want to use when delivering it to our learners. After you've found the content, the next pearl that I have for you, and I probably should have done this one first, is to actually think about your learning outcomes. And to do that, I recommend splitting Bloom's taxonomy into 2 levels. For those not familiar with Bloom's taxonomy, it is a methodology for writing goals and objectives to determine the outcomes that you want your learners to demonstrate at the end of class. And the cognitive level goes from, in this case, low to high, with remembering and understanding being low-level cognitive skills, and the application, analysis, evaluation, and creation being very high-level cognitive skills. The good news is the low-level cognitive skills are easily obtainable by the learners on their own time. And so for the pre-class work, we tend to write our outcomes based on those low-level skills. And for the in-class work, we rely on the other 4 levels. Also, remember that in order to have a really strong learning objective, you want to list out the audience, behavior, condition under which it will be demonstrated, and the degree or how well the students will perform. So list out your learners, what they're going to do, and then how well they will perform to determine how you're going to evaluate the effectiveness of your class. Now, if you have any questions about the behaviors, you can easily search for Bloom's taxonomy action verbs and come up with images similar to this one. They're all over the internet and freely available from multiple colleges that use these as part of their planning as well. And so you can look at the verbs, and that will help you to then design the in-class learning activities down the road as well. What if you can't find anything good? Well, now we need to talk about making your own content. One of the problems that you see with the flipped classroom, though, is everybody wants to talk about the content. And again, going back to Eric Mazur, we really need to get past that and treat the technology like air conditioning. let it fade into the background. That being said, it is very, very easy to make your own content these days. All you need is a computer and a microphone. There are multiple types of microphones on the market. On the left, you see a Samsung Meteor, which is a USB plug-and-play microphone. On the other side, you see a 3-pin Rode Procaster that will hook in through your computer. You need a separate adapter to be able to use the XLR cables, however. And in a bind, you could always use the headset that comes with your iPhone, although we tend to recommend avoiding those because you get a lot of hiss and static and other undesirable noise when you record through those. On your computer, all you need is the software that you are already familiar with. PowerPoint, if you're using a PC, has the ability to screencast built into it. Unfortunately, they took that feature away for people who use Mac, so you have to rely on using QuickTime. And Keynote as well will also allow you to record. So everyone should be familiar with these software platforms. They're pretty ubiquitous and easy to use. And all you need to do once you're complete is to plug in the microphone, hit the screen record button, and then you're able to capture your content as a video cast. Now, that being said, I do have one request that if you're choosing to do this, spend some time to learn how to design slides well, read some of the articles about Mayer's multimedia principles and apply those so that we stop having all of the death by PowerPoint that is also ubiquitous within medical education. One of the questions we always get from people who are new to the flipped classroom is, how do I know if my learners did the work? How do I know if they did the reading? How do I know if they watched the video, et cetera, et cetera? If you're in a site that has a learning management platform, a lot of times you have access to that data because learners need to log in order to access the content, and that data is collected by the platform. But if you're just doing this on a shoestring budget, then you've got to do some different things. One of the easiest things that you can do is what's called an entry ticket. So before you have your learners engage with the classroom content, they have to complete some type of test, and that can be as simple as a multiple choice test that you administer as soon as they walk in, or you can actually get creative and have them hand in different projects as homework, such as a mind map or an infographic, things like that. There are a couple of software platforms that also allow you to assess the learners as they go along. So Edpuzzle is one of them. This program allows you to embed questions into the video that you created. So if you're doing a screencast, you upload it into YouTube, you then drag and drop the link into Edpuzzle, and then you're able to write some questions that will pop up where you see the little flags at the bottom. So they can watch, and then all of a sudden they get to that point and they have to answer another question before they're able to progress through the video. One of the other tools that I really enjoy is Socrative, and Socrative is a quiz platform that's freely available to educators. It allows you to write fairly typical multiple choice questions, although you can also do quick questions, as you see in the bottom, with short answer or true and false. But the nice thing about the multiple choice is it will automatically grade things for you. You're able to create folders, and into those folders it will save your quizzes so that when you run it a second time, they're all available to you. And then the quizzes themselves allow you to import images. So if you wanted to put in an EKG or an X-ray or a clinical image, then it's very easy to do that. And then as you can see at the bottom, it actually puts an explanation as well. And when you launch this quiz, the learners are able to self-pace. You can withhold the explanation if you wanted. So if you were using this as a live teaching tool, they could answer the question and then you could explain it. Or if you're using it for a quick assessment, you can leave the explanation there for them to quickly go through on their own. So the next question, now that I'm pushing all of this content that I would normally deliver via lecture out as homework, what do I actually do in the classroom time? As I mentioned, this is where the higher order objectives come into play. So some examples. With the application, you could easily run case discussions. You could do high fidelity and low fidelity simulations, demonstrate procedures, or use some of the other low tech tools like scratch cards to do team quizzes. With analysis, you can do debates. So one of the fun topics here is to split the class in half and give half of them the pro TPA and the other half the con TPA and let the chaos ensue. You can have them go through an M&M case piece by piece instead of just presenting the digested topic to them. You can show a video of the sim case and actually have them discuss as a group what went well and what needed to be changed with the care of the simulated patient. And then at the final level, the creation or the highest level of the objectives, you could have them actually create an output that they then will use later. So you could have them develop a clinical case or a practice oral exam that they can then administer to another group. You could have them work on clinical algorithms. You could have them do patient handouts, so digest that information through the medical lens, but then make it approachable to a patient. So no shortage of creative applications that we can use when we're in the classroom. Polleverywhere is another tool that you can use to help break up some of that classroom time. So if you wanted to give the groups questions and then they can actually participate in real time, and this would be more akin to how Eric Mazur runs his peer instruction, where you deliver a short demonstration, have them try to engage in a high-level question, and when they are not really getting it right, turn to each other. And this is a wonderful tool for that. And then the final tool that I wanted to tell you about are the different infographic makers. And there's a wonderful example there on the right of an infographic created by Borean EM and the team up at Canadium. And you can have your learners create these for themselves and for your other learners who may not have been there, or even for your other faculty who weren't there. And they can be very helpful in digesting the information and distributing that information to the rest of your team. And the two that I really like to use here are Piktochart and Canva. Both are free on a basic level, but then have upgrades that you need to pay for. So pros and cons on those models. So that brings us to the end of our discussion today. So now you understand what a flipped classroom actually is and is not. You hopefully remember the history and understand that the effectiveness really shows that the learners love it. They don't really know in terms of how effective it is for learning outcomes, and that we need a lot more study in behavior change and patient outcomes, and a basic toolkit for going back to your department and applying the flipped classroom methodology for your teaching. Thank you for participating tonight, and I would love to take some questions.
I actually have two questions for you that are in the chat bot, if that's okay. One question from Thomas is, how can this best be accomplished when presenting to distant locations?
So we're talking more about screencasting, similar to what we're doing right now. So you really need to take some time to figure out how you're actually going to be doing the in-class part. The video casting part of things is pretty easy these days with YouTube and Vimeo and the other online tools that you can use to deliver the low-level content. Podcasts are the same way. But when you're actually working with a distant group, you're going to need to have some way that you are present in their classroom. And so for that, you're going to have to rely on a video conference service similar to Google Hangouts or YouTube Live or any of the more premium tools like GoToWebinar that we're using right now.
He said let's see, you answered the second question. He said, or perhaps embed an instructor. Thomas, you can unmute your phone if you'd like to clarify that.
Yeah, so we thank you for that. That was a great presentation. I'm really enthusiastic about applying this. So we present via some sort of a webinar or video conferencing, I guess would be the proper term. But so we have different residents in different locations. So as you're presenting, I'm thinking of perhaps I maybe get a chief resident or some other higher level learner at the site and kind of debrief them in what you just briefed us in, and then include them. And that's what I meant by embed an instructor who can oversee the activities, because sometimes I don't want to confuse activity with education, right? And I think you kind of implied some of that happens in your initial remarks, that just because there's a lot of activity doesn't mean they're actually picking up any content, unfortunately.
Absolutely. Yeah, so having a compatriot who understands the learning outcomes and what you're trying to achieve is definitely a doable strategy. That's what we use when we're using EM foundations with our learners. All of the faculty have access to the answer key, so to speak, with the cases and the key learning points. And so the learners go through Rosen's in our program, do the reading, and then go through the cases as a small group. And then the faculty have the case discussions, and those are available. We use a Dropbox-like program to make sure that they're distributed to all of the faculty.
Thank you.
If there are any other questions from the audience, you can either unmute your phone and ask the question, or you can type it in the question section on the screen. So Rob, let me ask you a question. This is a scenario that I faced a couple of years ago when we were really pushing this a lot in our conferences for our residency. We were really implementing a lot of flipped classroom style education. And then I was doing a 6-month eval with one of my residents, and we were talking about conference, and he said to me, "Why can't you just give me a lecture? That's how I learn best." How would you respond to something like that?
I think we've all heard that if we've been doing this long enough. So it's a great question. I think the best thing you could do there is to try and find out why the learner feels that lecture is the best way that they learn. And sometimes we have blind spots. Oftentimes we have blind spots in our own learning and our preferences. And we think we learn best via lecture because it's easy. But as we've shown, or as has been shown in the literature recently, students who capture all of their notes on a computer versus write them by hand do worse on their long-term recall. And I don't know about you, but when I sit in lecture and watch the learners, none of them are even taking notes. So they aren't even processing it half the time. And so I think showing them the benefits of moving towards the active model are great. Some people don't want to push out this content to the learners on their own time, and so they still do rely heavily on lecture. And there is a signal in the literature as well that maybe the real benefit of this style is the active learning. And so if we are able to incorporate a significant amount of active learning into our lectures, then we might see similar outcomes.
Yeah, you know, it's interesting. I was around just a few weeks before that 6-month eval. I was having a conversation with Gloria Kuhn, who many of us in court are very, very familiar with, certainly a mentor to many of us. And I asked her, you know, we're really pushing a lot of this, quote, new style education. And at that time, there was not a lot of data on it. And I said to her, do we know if this is really better? Certainly we know that there seems to be a very low retention from the traditional lecture. But all of these new things we're doing, do we know if they're really better or not? And she said to me something very interesting. She said, just wait about 20 years and you'll see everything flip all over again. And I thought it was very interesting. And then shortly after, I had this conversation with my resident during a 6-month eval. And I think the message that I took from it was, that many of our learners in our conference rooms have different styles of learning. Some learn better by audio, they hear it and they retain it. Some learn better by visual, some learn better by participating. Everybody has a different style. And I think it's important to keep that in mind, that many of the people who are in our conference rooms or classrooms or any of our educational events, someone out there is learning differently. And I think it's important for us to keep that in mind to make sure we're reaching everyone.
I think you have to be careful with that too, because I think there's a push from our learners to make sure that we're hitting their learning styles. And when you actually do the deep dive with the literature that way, there's not a whole lot of support that shows that if we tailor our teaching to independent learning styles, that we're going to actually change outcomes.
Really?
What is pretty clear is that we need to make sure that how we're teaching matches the application of the content. For example, if we're teaching a procedure, there's no reason we should be lecturing about the procedure, but should be demonstrating and then having them practice the procedure. So everybody needs to engage their kinesthetic learning style when they're learning procedures. And that makes sense when you're talking about that type of content. Likewise, if you're learning how to read an EKG, you really need to be a visual learner and read a lot of EKGs. You can't simply listen to a lecture and learn how to read EKGs really well.
Excellent point, thank you.
Rob, this is Al Tirado. That was a very good lecture, so we appreciate it. I was going to ask you, you mentioned about learning management systems, the LMS. What do you think is actually the benefit right now of having those LMS? Is there do they still fit in this type of model, just to like trying to monitor that they're doing their, or do you even think that that's necessary? I know that we have like we need to like monitor the asynchronous learning that they're doing too, but where do you think that they fit right now?
That's a great question. I don't think I have a great answer for you. The benefits are that you do have the ability to monitor your learners, but I think that also goes towards the trust and the culture that you're trying to build. So if your faculty show up every week and they're doing the work too, I think that rubs off on the learners and they tend to do it, and you may not need to monitor it as closely. That being said, there are always those hawks who are compliance monitors, and the data that your LMS can provide from that is helpful to prove that the learners are doing the work. These days, there are a lot of free, or not free, but alternative systems out there that you can purchase for blogs that allow you to kind of build in the monitoring, and so the large proprietary LMS systems aren't nearly as necessary as they were 10 years ago.
Okay, thank you.
Dr. Jody, I believe I saw your hand up there, is that right?
Yeah. I'm sorry, I was muted for a second. I just wanted to amplify a point that Rob said, and thanks, Rob, for this fantastic sort of introduction to this. And you really have to tailor your techniques of education to what you're teaching. And Rob said that pretty clearly, but it's super, super important. And the other thing I would say to people that are beginning to try this out is use this as an iterative process, that you try something, you figure out what didn't work, what worked well, you sort of refine that a little bit. So I have found in struggling with this for 10 or 15 years of trying to integrate more and more active learning, that use failure as your friend. So fail, but fail forward, find something that works a little bit better, iterate, learn from your mistakes. And I think if you just expect this flipped classroom thing to work the first time and to be perfect, you're going to find disappointment. And I think, you just have to iterate. And we're actually pretty good at that, being emergency physicians, but sometimes we just expect immediate success with a new thing when it comes to conflict.
That is a wonderful point, Chris. Thank you. I have had so many failures with trying to roll this out in various formats. It's constantly a learning opportunity as an educator to see how I can break this and then what I can do differently next time to make it a little bit better.
If anyone else has any other questions, please feel free. Okay, well, if that is all, I want to give a tremendous thank you to our speaker, Dr. Robert Cooney. Thank you all for joining us. Our next Cord Connect session will be on September 27th at the same time. The topic will be Curriculum Development 102. Looking forward to seeing all of, or hearing from all of you there. Thank you again to Dr. Cooney, and thank you all for joining us. Have a wonderful, wonderful evening.
Thank you, everyone.